Good morning, good afternoon, everyone. My name is Robert Popovian. I am the Chief Science Policy Officer at the Global Healthy Living Foundation. We are very excited to do this webinar for you all. This is a topic that Global Healthy Living Foundation has been engaging on for the last couple of years. It's called Formulary Exclusions. We've done a lot of work around it, and today we're going to have a webinar where we're going to be discussing the two new studies that we've completed, and we'll get at the end and let you know where they're going to be posted and so on and so forth. And without any further ado, if you have any questions, let's get started. But if you have any questions, please put it in the Q&A chat. We got tons of questions actually when we sent out the invite, and we asked individuals to provide us questions while they were registering. We got tons of them, so we know that there's a lot of excitement and interest on this topic. So without any further ado, let's get started. I'm going to introduce my colleagues and friends that are on camera today, and we're going to start with Catherine Hicks, who is our patient advocate. And the most important thing is that we always want to start with Catherine, and we will get her going soon, because formulary exclusions is just not a number. It impacts individuals and impacts patients, and that's why Catherine's here to really discuss and help us out. Next is my dear colleague, partner, Dr. Sydor, who is the Director of Research, Development, and Communications at Global Healthy Living Foundation. After that, it's going to be Sara Chea, who is our Research Fellow Extraordinaire, who joined us at the Global Healthy Living Foundation from University of Southern California School of Pharmacy. She's a third-year pharmacy student. And finally, it's Esteban Rivera, who is a colleague of mine, data scientist from Global Healthy Living Foundation. Esteban happens to be an economist too, so he's done a lot of the work with regards to the analytics behind both of these studies. And as always, we want to thank Ben Blanc, Veronica Rodriguez, Susan Jara, a slew of other people who have helped us out to produce this webinar. So without further ado, let's get started. So formulary exclusions, the background on formulary exclusions are formularies were originally intended to promote the use of cost-effective medicines over time. The purpose has shifted significantly. Over time, they've become profit-making machines, frankly, by the pharmacy benefit management companies. And we know from the state of Texas, when formularies are generated and all these rebates and fees and concessions are collected, only a minuscule amount, less than 0.5%, is passed back to the patient. In fact, majority of this is kept by the pharmacy benefit management companies or the issuer, which happens to be the insurer. But now these days with vertical integration, they're one and the same. So in other words, they're keeping all of this money. Very little of this this type of formulary management and formularies and concessions that happen because of these exclusions go back to the patient. So background on formulary exclusions, tons of people have done work on this topic. They know who they are, and you guys have seen some of the data that's been produced. The number of exclusions has increased year over year on an average of 34% between 2014 and 2022. Formulary myths and exclusions jeopardize patient well-being, and that's why Catherine's here to talk about her experience with formulary exclusions. A study of 775 patients by Xanda showed that excluding drugs from formularies increases cardiovascular events for patients. Over the past several years, multiple analyses, Adam Fine from Drug Channels has done a fantastic job quantifying the number of exclusions year over year. And really what we wanted to do, and that's our contribution that happened last year, we will go over what we published, but we wanted to look at not only the number of exclusions, but what those exclusions mean. Do they make sense from an economic or a clinical benefit to the patient? Last year, as I said, we published in a peer-reviewed journal, Health Sciences Journal. We got a lot of feedback for it. And what we did is that we looked at the Express Scripts formulary in 2022, and we analyzed whether or not the exclusions were beneficial economically or therapeutically for the patient. And as I said, we got a lot of interest on it. we estimated that about 42% of the exclusions were for mandated non-therapeutically equivalent drug to be substituted for the patient, and there were almost just the tick under 50% were not beneficial economically or clinically for the patient. And in fact, we found that about 10 cases, unfortunately, brand name medicines were being covered instead of the less expensive generics. And guess what? In 2023, I'm going to spoil the results a little bit. That number has gone up. So our intention in 2023 is to do two things. Number one, to update the 22 analysis of the Express Scripts, see where it went. Did the numbers increase, decrease? How did the patients fare? And then secondly, is to do a patient-centered prospective modeling of specific formulary exclusions by drug class with anticoagulants, migraine drug class, and psoriasis, topical psoriasis. The reason why is that when we talk about exclusions, we want to see how many patients are being impacted. Each exclusion impacts the patient. And that's why it's important for us that we had to do the second study to really quantify the number of patients that are being excluded. Is it 1, 10? Is it 1 million, 2 million? So we'll find out more as my colleagues will discuss. So without further ado, let's bring on Catherine. How are you?
I'm good. How are you?
Awesome. So take a few minutes and tell us about yourself a little bit and your journey as a patient.
Sure. I was diagnosed with JIA juvenile idiopathic arthritis when I was 6, and epilepsy when I was about 8 years old. So I am well into my 40s. So it's been about 40 years of living with two very serious chronic illnesses.
Catherine, you've experienced exclusions as a patient. What was it like? I'm sure a lot. What was it like? How did you manage that as a patient? How did it affect you?
Sure. So I'm on a marketplace plan. So every year I basically get a new policy. So I go through this about once every 12 months in some capacity or another, dealing with exclusions and things that may have been gone through the process the year before, but now I suddenly have a new policy because it's a new year and I go through it again. So I would say the most serious part of that for me was my medication was excluded for my rheumatoid arthritis. And while we were appealing it, I landed in the hospital with a very serious infection, which is very common when you come off of the medication I was on. And so I ended up in the hospital for 10 days and briefly went septic during that time because my body didn't know what to do. It was getting medication. I was in what my doctor considered medically induced remission at that point. The medication has worked for me for over a decade. It very well maintains 99% of my symptoms. And then when all the excluded, and my body just had to be taken off it with no taper, taken off it with nothing. And we went on the drug that was approved while we were fighting it. My body just went into full revolt. And so kidneys is usually where it shows up for me. If I'm going to get an illness, it's usually there because I have other comorbidities of kidneys and lungs from dealing with this for so long. And so I was in the hospital, and, being in the hospital with an autoimmune disease, it's just one of those things where your body is going to do what it's going to do. And it's doesn't always make sense. So I was of that 10 days, I was probably borderline septic for most of it and dipped in probably in the middle of that 10-day stay in the hospital. And during that 10-day stay in the hospital, my doctor was able to rush an urgent appeal through, but my body was not in the shape to actually take the medication because it's an immunosuppressant. So I literally went with no medication for my rheumatoid arthritis while we were fighting this. So it was about a 3-month lapse in care where I was very seriously ill. The majority of the biggest part of that seriousness was in the hospital, but because my body had to heal and recover, it's about a 3-month period where I had no medication at all for it and did what my doctor thinks that was the beginning of the permanent damage that has been done in my spine. From that time, that's when he thinks it started to happen. So it was not just the acute, I got an infection. It had long-term consequences for my body.
Yeah, and that's why we're here, why we want you to be here, Catherine, to talk about your experience, because each one of these exclusions has a patient behind it, right? This is
not only one, it has lots of patients behind it.
And we're going to learn more.
Yeah, and I have talked because I'm very open on social media and everything about my disease. I've talked to probably 10 or 11 people about going through that process. I was very fortunate I had a doctor, but I've also gone a doctor who advocated for me because I was definitely not in a position to advocate for myself in the hospital. But I've also advocated for myself through the appeals process.
So we're going to keep Catherine here. We're going to ask her to stay on. We're going to, when in the quick Q&A session, we're going to come back to her and ask her to answer some of the questions. Now, let's move to the first study. And I'm going to ask Sara Chea, who is our research fellow, who was our research fellow this summer at the Global Healthy Living Foundation, to come on. And Sara, welcome. I'm going to ask you to go over the methodology of the study that we did. It's a review and update of the 22 study. So Sara, take it on.
Sure. So our method for carrying out the study was first analyzing the 2023 Express Scripts Formulary Exclusion list in detail to determine what drugs were excluded and what drugs were included. We classified all of these drugs as brand, generic, or similar. And then we analyzed the exclusions based on the following definitions. So first, under the umbrella of clinical benefit, which is the third bullet point, we looked at the type of exclusion based on active ingredients. So this is based on the assumption that the patient is on a drug that uses such drug with a certain active ingredient for a certain therapeutic effect for a beneficial clinical outcome. So within that umbrella, an equivalent substitution is defined as a drug being substituted for brand, generic, or biosimilar with the same active ingredient. So for example, the combination pill of rosuvastatin and ezetimibe for cholesterol was excluded to prefer two separate tablets of ezetimibe and rosuvastatin. And next, a therapeutic substitution is defined as a brand or generic drug being substituted for a brand or generic with a different active ingredient. So this example would be reverse of the previous example, which was not in the exclusions list for this year, but if this said combination pill for rosuvastatin ezetimibe was excluded and only preferred atorvastatin, which is a different cholesterol medication, then it would be classified as a therapeutic substitution. So within a different category of clinical benefit, the exclusion would have had questionable medical benefit when they're forced to change the route or formulation of the drug or are told to switch to a different active drug altogether, which could lead to less adherence, more side effects, and decreased efficacy. Some excluded drugs even had no alternative substitution listed. So next, we reviewed the economic benefit of the substitution based on if a brand or generic drug was excluded in preference to a brand or generic drug. And usually we base the assumption that generics are cheaper than brand names. For example, Lipitor is the brand name for the generic atorvastatin, and the brand name is excluded on the exclusions list, which makes sense for economic benefit. And conversely, questionable economic benefit would be defined as if a generic was being excluded to prefer a brand name. So for example, on the 2023 exclusions list, zolmitriptan, which is a generic nasal spray for migraine treatment, is excluded for the preference of Zomig nasal, which is a brand name. And doing so, excluding a generic for a brand name is of questionable economic benefit, as this would not make sense or in the economic sense to patients as basic consumers. And the second scenario of questionable economic benefit is when a formulation substitution, such as the combination pill example that I drew in the beginning, is excluded, which can drive up overall healthcare costs if the patient has worse medical outcomes. So using these two judgment criteria of active drug component and cost, we put them together and evaluated if the exclusion had questionable medical benefit, questionable economic benefit, or both. And then we compared the numbers to all these categories to values recorded in the 2022 study.
Thank you, Sara. Thank you. It was very good. And just to remind everyone, the methodology that was used for the 2023 evaluation is identical to the one we used in 2022. And the reason we did that, we wanted to be consistent. We wanted to see the results, whether the results change year over year with regards to the new formula coming out in 2023. So we're going to have a poll question next. So our poll question is, what percentage of substituted drugs use the same active ingredient as the excluded drug? Is it 100%? Is it 75%, 50%, or 25%? While you guys are answering the poll, You will have time to answer it. I'm going to ask my colleague, Sydor, to come on. Anne, welcome. And please go over the results. Well, what did we find in 2023 and how did it differentiate itself from 2022? Take us.
Sure. So what we saw in 2023, not surprisingly, is that the number of exclusions continued to increase. The overall number of drugs that were excluded from formularies, the ESI formulary, went from 563 to 688. So that's a 22.2% increase. These were equivalent substitutions at about the same rate, therapeutic substitutions at a little lower rate, but importantly, no substitution. Drugs that were excluded for which the patient could not receive an alternative medication and therefore simply had to live with no treatment, doubled from 9 to 20, an increase of 122% from 2022 to 2023. Looking at the equivalent substitutions class, and we do see that equivalent substitutions overall are a little more than half, but many of these are different formulations. So there's a question of whether that's really substituting the same drug, because if you have a powdered drug that's sprinkled on food versus a drug that someone has to swallow, and they have a condition like dysphagia, a swallowing disorder, that drug that they're being forced to substitute may be something they cannot take. So the huge increase from 58 to 126 in different formulations among the equivalent substitutions is really quite concerning. Additionally, we see that brand name drugs are being substituted for brand name drugs, as Sara talked about. That brand name drugs are being substituted for generic drugs, which means the patient is having to pay for something that's probably more expensive than what their doctor prescribed, which is why it's not an economic benefit. Therapeutic substitutions on the upper right, again, we see brand name being substituted for brand name and brand name being substituted for generic. Now, when it's brand for brand, we don't really know which is more expensive to the insurance company. It may be more expensive or less expensive for the patient, but we can't tell because pricing isn't transparent. And this is why we talk about questionable economic benefits. Overall, on the bottom right, you see that we've gone from 47.9% of exclusions having questionable medical and economic benefits for patients to now more than half, 395 of 688 exclusions are of questionable benefits to patients for 57.4% total. Do we have the poll results? Okay, so the percent of substituted drugs that use the same active ingredient as the excluded drug is not 100%. Many more of the substitutions force patients to use a different active ingredient. Equivalent substitutions are actually just slightly more than half, which means that therapeutic substitutions and no substitutions are increasing at a faster rate and are a good bit over 25% of the total, not quite reaching 50% yet.
That was fantastic. We're going to move to the second study, right? So we want to quantify numbers now in three different distinct classes and see how many people are being impacted, right? So in this case, we actually looked at both the CVS and ESI formularies. So we looked at two different PBMs and we analyzed them based on modeling data. So in this case, we wanted to start off like how many people rely on commercial insurance. And we were able to estimate about 230 million people are estimated to be reliant on commercial insurance when you take out Medicaid and also DOD, VA, and also people who are uninsured. So about 230 million people in the United States rely on health insurance. If we go to the next slide, I'm going to ask my colleague, Esteban, to come on. And, we're going to do a poll, Esteban, right before you get started. But I'm going to ask Esteban to talk about the methodology that we use to go through the modeling process. So the question is, how many people could be adversely affected by the exclusion of a drug to treat atrial fibrillation in these two health plans. So CVS and also for ESI through their two PBMs. Is it 3 million people? Is it 1,500,000 or 50,000? And specifically related to atrial fibrillation. So take your time, answer the poll question. We're going to go to Esteban now. And Esteban, please discuss the methodology of how we came up with quantifying the number of patients, the modeling strategy that we used.
I would love to. Thanks for the introduction, Robert. So going back to that $230 million, not dollars, 230 million people, that's where this logic tree is built from. And then it branches off into 3 different drug classes, which the analysis is based on. So let's start on the left-hand side. From that 230 million people, combined prevalence of these 2 anticoagulants, which are atrial fibrillation and venous thromboembolism. Not going to say those again. I'll refer to them as AFib and VTE from this point on. But from that, the prevalence rates are estimated to be 1.3% to 3.4%. So we're taking that as a chunk of the 230 million people, and that results in 3.2 to 7.8 million people who could be taking one of these 2 medications. Now, from there, we're going to go to the market share that CVS and ESI have to determine the potential number of people that could be impacted by an exclusion from CVS or ESI. And based on a 25 to 30% market share, that number comes to 800,000 to 2.6 million people potentially affected. And so the logic's actually going to be exactly the same for psoriasis. So if you could move your eyes to the right side of the screen, I will go back to that 230 million people and base it on a 1.5 to 3% prevalence rate of psoriasis in the US. And that results in about 3.5 to 7 million people, depending on that range. And then apply the 20 to 30% market share again. And it comes to around 800,000 to 2.3 million people potentially affected by an exclusion. And to address the middle portion of this flowchart, I'm going to have to add a few more steps because of the nature of migraine. So we know that around 10%, give or take 1% of people in the US have migraine, but the number of days a person has headaches is how we determine, or not we, but how it's determined on whether someone is eligible for preventive medication or not. And so it's actually about a third of those people. And from a third of those people, we know that 40% are going to continue taking older treatments, which are non-CGRP targeting. So that's about, as you can see here, 4.1 to 5 million people. And that leaves 6 to 7.5 million left that may need preventive CGRP targeting medication. And then based on the market share, just like I did in the 2 previous examples, the resulting number of people that are potentially affected by an exclusion are 1.5 to 2.5 million people. And thank you very much for walking through this chart with me, because the next part that Sydor is going to show to you has a lot more detail.
We did this study, and Anne's going to go through the results, is because a lot of people get impacted by exclusions just in these 2 PBMs. We didn't even include the third one. By the way, the reason we didn't do the analysis, I'm going to be upfront with it, of Optum, is because Optum does a good job of hiding their exclusions. It's really difficult to decipher what they're excluding and including. To the credit of CVS and ESI, they're very transparent in their formularies, of their national formularies, exclusionary formularies, of what they're including and excluding. So, Anne, come on board. Let's talk about the results. What did we find in the second?
Can we take a look at the poll results first?
Sure.
So it looks like the majority of folks, 38% and 20%, 50% of you think that between 500,000 and 1 million people could be adversely affected by the exclusion of a drug to treat atrial fibrillation. So in cardiovascular drugs, looking at the number of people who have commercial insurance and are covered by the CVS or on the left or the ESI formulary on the right, what we see is that as many as 535,000 people in the CVS formulary would be likely to discontinue treatment. And that puts people at risk of very serious disease worsening. For AFib and VTE, people would be at risk of stroke, major cardiovascular event, just some really not good things. And it does increase mortality when people discontinue these drugs. So looking at the people who discontinue and the people who switch, because those who switch could have adverse reactions to the new drugs, as well as decreases in efficacy, we see that 580,000 people could have adverse events from an exclusion in CVS. If we add CVS and ESI together, we're getting pretty close to 1 million people who could be affected by excluding one cardiovascular drug from formularies. And that would be affected in terms of having adverse events. So that's, that million number is pretty close, and that 500,000 number is for only one formulary, excluding the drug. With migraine preventives on the bottom, CVS on the left, and ESI on the right, we have as many as 200,000 people discontinuing treatment, or if it were Nurtec, which treats both acute and preventive treatment, you would have as many as 374,000 people discontinuing treatment. That will increase disability and decrease quality of life. If CVS removes that from their, if ESI removes that from their formulary, it's 272,000 people who could discontinue treatment. And then adverse events, which is, again, increase in disability, decrease in quality of life, worsening of migraine. That could affect 717,000 people in the ESI formulary and almost 1 million people in the CVS formulary for migraine. So moving on to the last slide, we'll just take a quick look at the psoriasis drugs, the last class that we evaluated. Again, 80,000 to between 58 and 80,000 stopping treatment, depending on which formulary and which class of drugs. And adverse events are up in the hundreds of thousands, 226,000 if ESI excludes Humira, 311,000 adverse events if CVS excludes Humira. And as Catherine so rightly said at the beginning, when these drugs are excluded, when people are forced to change, not only do they have acute adverse events, but they also are likely to have a disease worsening. And that disease worsening can have long-term effects on a person, as Catherine described. So it's not just that the numbers aren't small. It's not just that the healthcare costs increase. It's also that this does harm to real people's lives.
And do you want to go over the next two slides by any chance? The patient journey and, quickly.
Sure.
This is a good visual depiction, frankly, what you talked about.
Right. So again, when just one drug gets excluded, hundreds of thousands of people to almost 2 million people can be affected just from one single exclusion. And that includes a lot of discontinuation of medicine that brings about worsening of health, also brings about increased adverse events that have healthcare costs and costs to patients. So then just taking a quick look at the next slide, again, we just sort of want to make the point that Humira is eliminated. We have almost 890,000 people who could be affected because they have commercial insurance, they have psoriasis, and they're in the CVS or ESI formularies. About 80,000 of them could discontinue, and many, many more could have adverse events.
And something else I would like to mention too is Humira is also a drug for RA. So this doesn't even really give a clear picture as to the amount of people who is truly affected, because a lot of these drugs are used for multiple diagnoses. So I just saw Humira here and wanted to step in, as that was one of the drugs I've taken in the past for my RA. So wanted to make sure that was also said here, that the idea of this is the data for one specific use of this drug.
Correct. And that's so important, Catherine, because this is just for the people affected by psoriasis. When we looked at the number of people taking a drug, when we looked at the market share of these drugs to determine how many people could be affected by by an exclusion of any one of them, we were looking at the market share for people with specific diagnoses, not for the market share of the entire drug.
Thank you, Anne. Thank you so much for everybody so far. What I'm going to ask you guys, start putting your questions in the Q&A. We will go through them. Obviously, as I mentioned, when we sent out this invite, we had asked for individuals to send us questions in advance, and we got a ton of questions, and we're going to try to intertwine the questions that we get live here versus when we get the questions when we got the pre-questions from during the registration. So before we get started with the Q&A though, our plan is this. You heard about 2 studies. Both of these studies have been already submitted and have been accepted for pre-publication on a website. You see the links here. We will be sharing you guys can get the QR code and everything else. You can take a look at the studies for yourself. You can review the data. Let us know what you think. We are preparing both of the studies to be submitted for peer-reviewed publication. We're in the midst of doing that. Anne and I are working at it. Sarah's going to be the primary author on one of the papers. I believe, Anne, you're the primary author on the second paper. So I'm usually the last author because I just have the idea and other people do the work. But so we will be submitting them and for peer-reviewed publication. But because we wanted to get this information out as quickly as possible, they are in pre-publication format available for anyone to take a look at it and look for themselves and let us know if you have questions. This is the whole purpose of pre-publication, is to people to comment on it and everything else. So let's get started with the Q&A. I'm going to answer some of the questions. I'm going to ask some of my colleagues to jump in and ask other questions. The first question that we got tons of it, as I said, during the registration, I'm going to go to that first question. A lot of common questions was, what is the main reason why PBMs exclude medicines? And I'm going to answer this question. The main reason is because they make more money off of it. When they exclude a drug, it's rebate contracting. They can basically leverage the other companies that they want to include to give them more rebates and discounts and concessions and fees and so on and so forth. And as I told you, or I showed you on the Texas data from the state of Texas, they don't pass any of it to the patient. They pretty much keep all of it, as they are now integrated vertically between the insurers and the PBMs. So the main reason is rebate contracting. And one of the things that always will come up with insurers and the pharmacy benefit management companies, and they will tell you, well, we're excluding X drug and including this one because it is better for us from a net cost perspective. I have no doubt about it. And I believe that the net cost to the PBM is lower, but that's to the PBM. When a patient shows up at the pharmacy counter and they have a deductible or a coinsurance, they're paying off of the retail price of that medicine. So guess what? When they're excluding a generic drug in favor of a brand name drug, and they say, well, the net cost of the brand name drug is cheaper for me. Yeah, they're right. It's cheaper for them, but not necessarily cheaper for the patient. And, we're all about the patient here in GHLF. If they're overpaying, that's not the case, is that they are being harmed. Okay, the next question, I'm going to come to you, Anne, because we got also a lot of questions about ERISA plans. So will federal legislation, if we pass federal legislation, and we saw today actually that the Senate Finance Committee took the first step into moving legislation for PBM reform out of the committee into debate for the full Senate. Will federal legislation supersede ERISA, basically? And that's one of the questions that we got a lot of.
Sure, and that's a really important question, and it is the reason why that bill coming out of committee today and getting to the stage where it'll be presented is so important. Federal law supersedes all state and local law and policy. So if we pass a federal law making these transactions transparent, limiting the amount of rebates, just kind of putting in some regulation to protect patients at the federal level, that will be a very, very good news for patients.
Absolutely. And, in the previous webinar we did, I'm going to plug our one we did a couple of months ago on accumulators and maximizers and the work that Esteban and Ann did. That's the same case. You can pass state legislation. It impacts state regulated health plans. If you really want to have everybody covered and protected, you need federal legislation, and that's why. All right, I'm going to go to a question here. And I'm going to come back to you actually on this one. So one of the questions submitted on for the Q&A chat is, do you believe that this type of activity increases healthcare costs overall?
Absolutely. And I think there's some good data on that. It's piecemeal is the problem. So there's the data that you mentioned from Exenda that showed emergency department visits went up, healthcare utilization went up for a cohort of 775 people forced to switch their cardiovascular medication. We definitely see increases in the rate of stroke, which is among people using drugs for AFib and VTE. And increased rates of stroke are certainly going to increase healthcare utilization. So we definitely see these adverse events having downstream costs to the system, as well as those really pretty awful effects on patients.
Next question, I'm going to go to Catherine. So you're a patient. You've gone through exclusions. It's impacted your health. How do you fight back as a patient? And specifically, what if you don't have a good advocate in a provider? How do you get around that?
I'm very blessed that I do. And I know that is such a privilege because I work with so many in the community in my online advocacy who don't. I would say reach out to fellow patients, because if I've been through this, there's thousands of us who've been through this, to get tips and advice. And it's a long journey. It's 30 to 60 days of constant nagging, constant pressure. And when you have to do that yourself on top of an illness, sometimes you can't do that. But reaching out to your community and finding out what worked for them is sometimes a shortcut. Also, really knowing the appeals process inside and out, because I had another issue with my insurance about my prescriptions, and I was told 43 different things by the insurance company. My dad was always fond of telling me when I was dealing with the health insurance, just call back until you get the answer you want. And that's kind of the truth. So educating yourself on what that policy is, knowing it as well as you can if you have to advocate for yourself, is so hugely important, because you can say, no, I read your policy. This is what you said. If you're not the person who gets me this, great. But also if you have a trusted family member or friend who can help you through it, especially if you're in acute disease flare. Like I said, I was in the hospital. There was no way I would have been able to continue fighting for myself, but I was very lucky. My doctor was livid that it came to that for me. So I had that advocate, but because I was also so young when I was diagnosed, my mother has advocated for me. My best friend has advocated for me. My father, my stepmother, I've had to have other people step in when I was unable to do it. I now, doing this kind of work with you guys, going to my state capital, going to the Hill, I'm much more passionate about doing it myself, but that often comes at a cost, so sometimes I do have to lean on other people to do it. But what I find the most helpful is talking within the community of patients with my own diagnosis has been hugely helpful in understanding what can happen, what should happen, what has happened for other people, so I can go in and as informed as I can, and leaning on, for me, my best friend to make sure it was happening. She was the one, when I was in the hospital calling the doctor, she was the one who was also with me every day. In the past that had been my mother or my father, but in this particular instance I mentioned at the beginning of the call, it was my best friend who stepped in and said, don't worry about it, I got you. So if you have that person, that's great. But sometimes we don't have those people, it's educating yourself in the process. And let me tell you, finding that process, I have a Blue Shield plan, was not as easy. They hide these things from you. They'll just say, you have 30 days to appeal, but they don't necessarily tell you how to do that. That's when reaching out to your own community and saying, hey, does somebody have this, or somebody, do this. That was the most helpful to me, at least knowing that someone else had been through the process and how it worked the first time I had to do it. Now I'm fortunate that I can just say, you guys approved this last year. And I just transferred over. So now it's not as painful for me. So once you do it once and you have it in a record somewhere, it does become easier to do again if you need to, but it's still not easy. Easier than absolute mess is still a mess. But those are the kind of the ways, if you are blessed to have a doctor, they should be the one advocating for you, but not everybody does. Some doctors are tuned out and checked out once you're out of the room, but those are what I would recommend.
Thank you, Catherine. That's very helpful. So one of the questions that has come up is, Sara, can you explain to us again, what is an economic, how do you get a clinical or an economic benefit in the analysis that you did for the 2023? Can you just elaborate a little bit more or re-explain?
Okay, so for the clinical benefit, we're primarily looking at clinical outcomes. So we're talking about side effects and the overall disease state. So in evaluating clinical outcome, we're looking at how we're doing that, because every disease state has a different clinical outcome or measuring state. We are looking at the active ingredient. So we just assume that patients want to stay on the same active ingredient. And for the economic outcome, we go under the assumption that the generic is cheaper than the brand name, and usually we want the patients to be able to afford their drugs and the insurance to be able to help cover these costs. So naturally, the more cheaper drug would be the one of economic benefit.
Thank you. Thank you, Sara. Question we got tell us about, what does vertical integration mean? Esteban, do you want to take a stab at that? What does vertical integration mean?
Robert, I wish I could, but I definitely think that you are able to provide a much more accurate definition than I.
That's fine. But let me tell you what the vertical integration is. It's integration that used to happen horizontally, which is one PBM buying another PBM, buying another PBM. Vertical integration is when the PBMs started buying insurers or insurers started buying PBMs. And now what's going to happen in the system is that not only PBMs have purchased insurers, but now they control all the specialty drug dispensing in this country. About 80% of specialty drugs go through PBM-owned pharmacies. So not only they control now formularies, they are the issuer of the insurance or the plan sponsor, technically, and also they're doing all the dispensing. So they're the judge, the jury, and the prosecutor when it comes with drug benefit program, unfortunately, in this country. And I want to come to you for the next one. We got some questions about self-insured plans. Don't self-insured plans have a lot of control over this? I mean, we heard this in the accumulator one too, remember? Because it boils down to the main thing that, yes. So go ahead and answer. Do they have control? They can do it. They don't have to take these exclusions, right?
Well, it's an important question. And part of why it's an important question is for patients who are in employer-funded plans, especially those small employer-funded plans, you can go to your human resources person and ask them to get your specific medication added to the formulary. And I encourage people to do that whenever they experience exclusions. At the same time, every time you add a drug to the formulary that would have been excluded, the premium that the company, that the employer is paying skyrockets. And so they can only do this so many times before they have to start increasing their employees' premiums as well as their premiums. So that flexibility is really a double-edged sword. Catherine, did you want to add to that?
Oh, there we go. Yeah, unmuted. Yeah, I think the general idea is what Robert talked about, right? The idea that we don't have anywhere to go, right? We don't have any alternative means, right? I can't say I can't get this drug from you. I'm going to go somewhere else. It used to be, when I was younger, that there were 2 or 3 different approaches that I could take, right? I could go to one pharmacy group or one pharmacy. I could go to a different place. I wasn't tied in as much to just one person in one group, right? So I could say, okay, I can pivot left or turn right, and I might have another way of approaching it. We don't have that as patients anymore. So if you tell us no, the only thing we can do is say, please tell us yes, right? And that's not, and if you still tell us no, there's no other further thing we can do, right? And I have had many friends who have had to take less effective drugs because they've been told they've gone through an entire appeals process of multiple layers, and they're just told no at the end of that. And then there's nothing they can do. So they're suffering long-term consequences because it's basically a monopoly. There's no other way to put that in most cases. It may be I may have Caremark and you may have, another group, but it's still a monopoly in the fact that there's no choice in that for us as patients. And that truly limits the care that doctors can offer us. My doctor was absolutely livid that he couldn't get me what he knew worked for me, that I'd been on for 8.5 years, that he knew worked for me because we tried everything else. And that goes into step therapy and a whole nother conversation that we had to go through previously multiple times as well. And so there's so many barriers to care that this one is just can have such dire consequences that people who are making these rules don't understand. And they're just such a cold process. They're just such a cold process of my doctor sends in paperwork, they go to some unknown person, there's no transparency in the process, and we get a letter back. Maybe.
So Catherine, thank you so much, because one of the things, this whole thing is a red herring with premium increases, right? That's all you will hear from them. When you have when 3 entities control about 80% of the prescriptions going through the retail process, and they control about 70% of the specialty dispensing, it's not a free market here. It's an oligopoly we've created. But, we heard the same thing, right? You heard about, well, if we don't exclude these drugs, therefore we can't leverage them, and therefore your premiums are going to go higher. Esteban, did we see that in the accumulator maximizer?
Before we go to Esteban, I will say my premiums have been going higher regardless.
Absolutely. And we have data to support. Esteban, why don't you talk about accumulation maximizer? Because we heard the same argument then, right? And what did the evidence show, the analytics that you ended up doing?
Yeah, the analytics have continued to show over the course of these years, as legislation has been passed, that there has been virtually no significant effect on premium prices. So that argument just really doesn't have any statistical validity with the current data set that we have right now, which is updated through 2023.
Yeah, it's the same thing. We always hear it's a red herring that the insurers and the PBMs put out there, that the premiums are going to go higher. If we don't exclude drugs, premiums are going to go higher. If we don't implement accumulators and maximizers, premiums are going to go higher. And we haven't seen any evidence of it. So
yeah, and I'll state, even from 2023 to 2024 on the California marketplace, my premium for my plan will go up 20-ish%. And so you're raising it anyway. So there's already sizable, I pay, a lot of money to be covered. I expect to be covered. It's kind of one of those conversations you have as a patient, like I'm paying through the nose for an individual marketplace plan. Even with subsidies, I'm paying through the nose for it. Why are you not covering the things that are going to keep me from a 10-day hospital stay that's going to cost you? My 10-day hospital stay probably cost them $300,000-$400,000.
That's right.
My drug was never going to cost them that amount.
It's being
even over the lifetime of my drug.
Penny wise and pound foolish, right? They're looking at the micromanaging drug costs because they can. But anyways, so the other question that we got actually for registration was IRA, Inflation Reduction Act. What is the impact of what is going to be the impact of Inflation Reduction Act? We're going to see more exclusions, less exclusions. We're not going to see any differences. The bottom line is with IRA, IRA does some good stuff, a lot of horrible things. It does price setting for pharmaceuticals, which has consequences on innovation long-term. Let's not get into that. What is going to happen with IRA, though? Because of three reasons, insurers and PBMs are going to have an built-in excuse to exclude more drugs. So number one, what IRA did is that it transferred all the liability rightfully to the PBMs instead of the government picking it up after they meet a certain threshold. The second thing it did is that it capped premium increases in Part D over several years. And the third thing that they did is basically put a cap of $2,000 per patient, which is great. Nobody's arguing, but they're going to use this as an excuse. What the PBMs are going to do is go back to the federal government and say, look, you've capped my premiums, you've capped out-of-pocket costs for the patients, and by the way, you've transferred all the liability to me. So IRA, without a doubt, it's going to ratchet up any kind of administrative burden that we already see, whether it's step therapy, prior authorization, and exclusions. They're just going to get on steroids, and we're going to have more and more of them because it's going to be a built-in excuse for them to go ahead and do this with the administration. And there's no discussion about that, right? We talk about the insulin caps, fantastic. We talk zeroing out-of-pocket costs for vaccines for seniors, great moves. We talk about price setting, impact on innovation, very poorly done. Nobody knows what the consequences, including CBO basically says there's going to be consequences. But nobody's talking what's going to happen to the benefit design and for seniors. And in my opinion, it's going to be impacted. I would invite you, basically, we just did about 2 episodes ago a whole session on this in Healthcare Matters, which is a podcast that Connor Mertens and I host. We talk about healthcare policy issues and the impact on patients. I invite you to listen to it. Last question I'm going to have, it has to do with Humira and biosimilars. One of the requests is that, are you going to look at the Humira now that there's so many multiple biosimilars are in the market and coming up? And what do we see in the 2023 formulary? And Sara, you can chime in because you and I and Anne had this discussion about the 2 formulations specifically by Amgen. What happened in that formulary with regards to ESI? What did we see with that?
So, Sara, do you want to take that, or would you like me to do it?
Yeah, I could just state what happened. So on one of the 2023 formulary exclusions, excluded a certain Humira NDC code, and this certain NDC code was excluding the NDC code of lower cost and included the NDC codes of higher cost. So that's just another way that they're using their leverage to decide what is covered and what is not, even to the specificity of a certain NDC code, which is kind of like the barcode of a drug.
And anything to add? I mean, the bottom line is that Amgen came out with a biosimilar for Humira. They priced one at 10% less than AWP, and then they priced the other one at 55% AWP, and they had 2 different NDC codes. What we saw in both formularies, CVS and ESI, both of them excluded the lower priced one and included the higher priced biosimilar. So why? And do you want to say why they do those things?
Well, I think we know why they do these things, right? The higher cost drug gives more room for rebates and refunds than the lower cost drug. And so ultimately, it may be higher cost to the patient, especially while they're still paying their deductibles or their copays, but it's lower cost, which means more profitable to the insurer and the PBM. So the other piece of that question that I want to quickly address is whether or not there's been analysis of the effects on patients who have been forced to switch from a biologic to from the originator biologic to a biosimilar. And there are studies out there. And we synthesize that data to come up with what the discontinuation rates and adverse event rates would be. So I would refer you to the details that are in the paper that we've put on the preprint server to learn more about that. But there is some data already out there, and I expect more will be generated as more biosimilars come into play. And finally, within the questions, there are so many questions about, did you look into this? Did you look into that? And we can't boil the ocean with one study. We have to limit ourselves to looking at certain specifics. But I want to thank the audience for all of these great ideas about further research that we could do, because it's very clear that formulary exclusions are impacting patients in very negative ways.
Thank you. And perfect way to conclude. I would ask everyone to go on the pre-publication server, take a look at the studies for themselves. Thank you, Ben. Thank you, Veronica. Thank you, Susan. Thank you, everyone who participated. Thank you, Catherine, especially for being here as a patient advocate. We look forward to hearing back from you. This is a recorded webinar. It will be posted on YouTube. If anyone has any questions, both publication server articles have my straight email address. You can email us. We have nothing to hide here. We want to have these discussions because this is important, because every exclusion impacts patients and every patient is important. And patients do get harmed by these exclusions. These are not some binary, non-consequential decisions. Thank you, everyone.